Thank you for taking the time to attend our presentation, Interoperability, Realizing Your Vision. Our speaker today is Michelle Snyder. Michelle is a solutions engineer with IATRIC Systems focusing on the interoperability needs of hospitals, networks, regions, and states. Michelle has participated in EMR implementations and conversions, HISP and HIE implementations, EMPI management, and interface management and testing. She is a registered nurse committed to the mission of educating the healthcare community about interoperability as a means to improve patient outcomes. I'll now turn it over to Michelle to get us started.
Okay, great. Thank you, Sandy, and welcome everyone. I'm really happy to have you here, and I look forward to bringing you through our webcast today, which is Interoperability, Realizing Your Vision, and hopefully you'll get some great tips here out of today's webcast. And I encourage you to ask questions. The way that we do that in these webcasts in order to keep things organized and moving along is that we ask you to put the questions in the chat section, and there will be a couple of times throughout the webcast that I'll go through those and answer them as they come in. So we have an agenda of just kind of short and sweet here. We're going to go over some of the main goals around interoperability. We're going to discuss some of the types and definitions, and we're going to talk about how to prepare for interoperability at whatever state you're in. How do we get you to that next level? And then we'll go through any additional questions and answers. So I want to start with just a definition. The HIMSS definition is pretty straightforward, and I think we can all agree on this. Interoperability describes the extent to which systems and devices can exchange data and interpret that shared data. For two systems to be interoperable, they must be able to exchange data and subsequently present that data such that it can be understood by a user. And that's all fine and good, right? But I think what I consider it, as I've been trying to work with people and help them to reach that goal, is it really is the act of taking thousands of proprietary systems that were created as good old standalone, I don't need anyone, I am king of the hill, you can't boss me around attitude, and making them share information. And that's really what it comes down to. It's a lot of work trying to herd cats, probably, is what it feels like sometimes. But the end is sweet, certainly. Once you get there, it is really worth it. Each of those little milestones along the way, as you see things coming together, make it all worth it. So there are three main goals that are defined by the ONC. The government has listed these as their main goals of implementing interoperability: to improve health outcomes, to improve health care quality, and to lower health care costs. So as we look at these and we kind of pull those apart, improving health outcomes, so that goal is pretty, I think we can all agree on that. And ways that we can do that are to get information to our clinicians more quickly and to the people who are requesting it perhaps in other facilities, other institutions, other receivers out there. We also want that history to be accessible, and we want to provide clinical decision support to our providers so that they can make decisions more quickly, and they will be the right decisions. So the more information they have, of course, that makes total sense. And we want to decrease the risk of any errors. You know, that might be through transcription, missing information such as allergies, shared problem list. And really, as we look at our three goals, those are the same things for each of these that we can do in order to improve healthcare quality and in order to lower healthcare costs. We're going to really look to perform these same actions in order to meet each of those three goals. So by working on one of these things, we're actually working toward all three of those goals. So that's kind of what we are going to work on and review today. So the advantages, of course, are pretty clear. It just makes things more efficient. We're going to reuse that data over and over again. We're not going to have all of these disparate systems trying to send the same information. We're going to be monitoring. It's going to be all in one place. We don't have to have three sets of monitoring options. We'll have alerting, and it'll be electronic from one place. And it will be a shorter implementation time. once we get there, of course, is going to be safer for our patients. Certainly no transcription. That's one I lean on a lot because I've had to repair a lot of errors in the past around transcription errors. That is just one piece, but it's one that hits home to me because I have had to repair those problems in the past. It will decrease cost. We can have 3 interfaces that do the same thing from 3 separate systems, or we can bring it to one place and have just one. We're going to talk more about that as we move on. So really streamlining our processes, streamlining the communications, and we will realize some decreased costs. And having fewer ins and outs is how we do that. So HIMSS has 3 different types of interoperability. The first is foundational. And what that does is really just get things from point A to point B, system A to system B, whatever those are. It's unidirectional, so it just goes the one way, and it is not required that the receiving system is able to interpret the data. So basically you're just dumping that data into something. It's not tricky, it's just send it there. You want to send it electronically and it gets there. Certainly that's important, and over time, sometimes that's all you need. Just get it over here and I will take care of it once it's here. You might have lab orders that just go to some lab system and they just go there and then they manage it once it gets there. You haven't done anything to make sure they can understand it. The bedside device that's sending results to a text file. Discharge messages that just dump into a housekeeping app and then they have to interpret, decipher, okay? So it might look something like this if we're thinking in the real world. This is my friend Dan, and he's talking to Pierre, okay? And he's telling him he's diabetic, and Pierre, who only speaks French, has no idea what he has said, so he doesn't understand that. So this is basically foundational interoperability in its most basic sense. And then the next type of interoperability is structural, and you can see that these arrows are going both ways. And I've got the colors on these, as that blue is sending over to the orange, it's turning orange, and vice versa. As they are sharing information, you can see that they have uniform movement of healthcare data, all right? They have a syntax for the data exchange. Each one will understand the other. It will be interpreted, so when we send it to you, we know what you're expecting, and the purpose and meaning is preserved. So it's going to be understood by the recipient. And this ensures that it's interpretable at the data field level. So we have the structured data. We're making sure the recipient can understand it. We're sending it in the way that they said. Maybe you have a spec that you're working to. And so that might be our lab orders that go to a reference lab, but now they actually create the visit and the order in the reference lab. We have done some transformation of those messages. A bedside device, the results might go to your critical care system and they drop right into a flow sheet because the recipient knew what was in each spot and could populate a flow sheet. Discharge messages to that housekeeping system, now they actually update the bed status to dirty upon receipt. So the patient has been discharged and they know that that bed needs to be cleaned. So we've done a little bit more with that data at this point. So now, if we consider our friends Dan and George here, or Dan and Pierre, now it's understood by both. Everybody understands what is being said from one to the other, okay? The next type is semantic interoperability, and this is kind of the holy grail here. This is what we're all working toward, is semantic interoperability. And this picture is the most basic, so when we talk about this graphic, we're going to elaborate on this as we move along. What semantic interoperability really is the 2 or more disparate systems that are able to exchange information in a way that's usable, and it's structured and codified for interpretation by the recipients, and it supports electronic exchange of patient summary information. So now we're really getting into the meat of this, where the patient information is going to be shared just as we've all been working toward. And the goal, of course, is improve quality, safety, efficiency, and efficacy of healthcare delivery. Okay, so that is what we're working toward here. So now we've talked about our three types. We have our foundational, which is really just one way. The recipient doesn't really need to understand it. We're just sending it. We have our foundational, and we have our structural, and both sides will understand. And then we get into semantic, where everybody's really doing some, you're sharing with more than one system and really able to support all those disparate systems sharing information. So I do have a poll question for you, and I'm wondering which of these describes interoperability for your health system. Is it foundational, structural, semantic, or are you unsure? So if you can answer that question, I'll give you a chance to do that. And I'd also like to encourage you to enter those questions into the chat box. So if you have any questions throughout the presentation, please be sure to enter those there. And I'll get to those when I stop for questions. After we do this poll question, I'll be happy to answer any that you have. And this, let us know if you have any challenges. Even if there's something that I haven't seen, I'll be happy to research that for you and get back to you. So if you have any particular needs or goals of this call and webcast, then please let us know. We'll be happy to get to those. Okay, I'm going to close that poll now, and let me just take a look at that. All right, we have 50% of you with semantic, fantastic, 25% with structural, and 25% are unsure. So, and that's normal as well, that we'll have some people who just aren't really sure what they've got, or maybe it's a mix. In some cases, you have some sharing going on. And we're going to dive into this more, so not to worry at all. We're going to dive right in and tackle that. Okay. So I'd like to just check and see if there are any questions in our chat window at this time. If there's none, I'll go ahead and move on. We haven't really gotten too deep here yet. We've just basically talked about a couple of things.
Sure thing, Michelle. We do have a question.
Okay. Oh, great.
Semantic is what we need. We have connected Meditech, Allscripts, and Epic before.
Okay.
Sorry, I misread that. Sorry. Have you connected Meditech, Allscripts, and Epic before? Oh, I'm so sorry about that. My bad.
Thanks. That's all right. I was waiting for the rest. Actually, yes, we have. So we're going to get into that a little bit more, but we have Meditech systems, Epic systems, Allscripts, NextGen, Cerner, Saurian, Millennium, all those different types, and we have been able to assist people in managing those types of transmissions of information bidirectionally and in a way that is per the spec. So whatever you're looking to do, however you want that information to be transformed along the way, we can do that. So one I was just working on recently was for a site that had an Epic hospital, and they had Allscripts and NextGen, and they were looking to be able to share that information, see the patient record in the Epic system, and they weren't sure if they were going to move to Epic Ambulatory for those, so they needed a more long-term solutions. We were able to convert those so that when it got to Epic, they could see it, they could get the problems, allergies, and meds, they can reconcile in there. So that was really interesting and was exciting to see them meet that goal. So, but we'll be getting into a little bit more of that as we move along. Any other questions at this time?
Not this time, Michelle.
All right, thank you. Okay. So, semantic interoperability doesn't just have to be that little graphic that I showed you with the three systems, and it hardly ever is. If it, if it's 5 minutes in and you're already changing, right? That's kind of the way it goes. And certainly in some cases you'll have an interface engine for one of the systems. So in this case you can see System C, and by having semantic interoperability, it doesn't mean that you've got one engine or each of the hospitals or facilities or networks that are associated with an HIE, for instance, they might have little engines all around. We see all sorts of crazy graphics of how people are getting it done, and getting it done is really the goal, but we can try to refine that so that it's more efficient, certainly over time. So as we're looking at this, you might also have a system. Here I have system B, where internally there's a bunch of interoperability going on. It doesn't have to be all of this external interoperability with other facilities or regions, networks, states, whatever. You've got within your own hospital, if most of you are from hospitals, which I think you are, in most cases you've got some really significant interoperability going on internally. Order entry to, pharmacy and lab, radiology, you've got documents going, you've got bedside devices that are feeding nursing documentation or provider flow sheets. So there's a lot of interoperability going on there that's very complex and not always one system. If you've got best of breed for your pharmacy or your ICU or your OR, then you've got a need for some interoperability there. Otherwise, you've got pieces of paper from the OR and you send that to the nursing unit. I am working with a site now that prints their OR summary and then they send it to the unit. But they have it is electronic. The OR suite has an application that they use, but it is not interfaced or integrated with the rest of the system. So we'll talk about some of those options as well. So within a hospital, within one facility, you can have a lot of interoperability going on there as well. But usually what we see, and when we're called in, we've got systems that need to interface with a lab. Maybe you have LabCorp or Quest or any of those big lab systems, radiology. You're going to your physician offices, an ambulatory system. So that will happen a lot. That's what we see. That's a really common example of when we'll be helping people. And then you have system B, might be going to the same exact lab or RAD or ambulatory provider office. And similarly, even though system C has this little engine here, they're doing the same thing, and they're just feeding it from their engine rather directly from their EMR. And so these are all different things that you might see happening. And as you think about refining that and making it more efficient, a lot of times what we'll be doing is working with people to see if we can, as the epitome of what's the goal of most of the people we work with, is to have that one interface engine in the middle that everybody can send to, speak to, share information. And if one of those systems or more has an engine that they are using, they certainly can continue to use that in order to feed that other engine. What we're going to be talking about in a little bit is really taking advantage of what you've already got, the architecture that's there. And if you've already got that and all of those interfaces are already populating that smaller engine, then you can capitalize on that to feed the network engine, the region engine, statewide, whatever, HIE perhaps, so depending on your situation. And then what you can do is take from that engine and you can look to that lab and RAD and ambulatory physician EMR, and I've added a couple of others here. You might have a QA system, PHI, billing accounts receivable, any of those that you need to send information to. You can do so from the one engine for one or all of the sources of information that feed that interface engine. So let's talk a little bit about semantic interoperability, because I think we can all agree that that's what we need to do. That's where we need to get, and I know some of you have some level of semantic interoperability. And in the ONC's 10-year roadmap, which is really, I was a little scared to read it. It's quite large, but I did read it, and it was very interesting, and I ended up really feeling like they had taken a very practical approach, and I liked the way it was written. So I encourage you to read that. So it's all about putting that architecture in place to send, receive, find, and use common clinical data to improve health and healthcare quality. And if any of you did the, I'll call it homework, if any of you participated in the cryptogram that I sent you, I wanted to, some of you registered a little bit later. So I sent this cryptogram. I love puzzles, and I think they are the perfect way to pull together a discussion around interoperability, because I put this out there, asked you to participate in completing the puzzle. I don't know how many of you did it. I sent out the answers yesterday, but I have here, we must send, receive, find, and use a common clinical data set to improve health and healthcare quality, just like we just read there. And the whole point of the cryptogram is, once you know what A is, so we know that A is actually a T, we can fill that in. So when I sent you this, which really didn't look like much of anything, I gave you a couple of answers to get started, you could fill that in and complete the rest of that. And that's really what we're trying to do with interfaces, with the things that we're pulling together. Once we have that common map, we can complete the rest of it. We can complete the rest of the puzzle. So once we know that M is A and D is B, now we can communicate because we have the key. Okay, so that's really what we are working toward, and that's why I used this opportunity to treat you all to a cryptogram, get back to puzzles, school days here. So as we're looking at this, the interoperability roadmap that the ONC published, they had 10 guiding principles and checkpoints, and I just mentioned how pleased I was at how practical this approach was. And their very first principle is build upon existing health IT infrastructure, and we'll be talking about that more. We're not going to dive into each of these because it would be a couple-hour session, but I've chosen a few that I think we can really do something about, and we can act relatively quickly to improve on these. So one size does not fit all, and boy is that true. You know, I'm working with some people who are, you know, they want the best, but they just don't have a need for a huge interface engine. They're not going to be creating a large HIE that's statewide. They just want something more practical. So we look at the options. Iatrix Systems, we have an interface engine, and we also are a reseller of a couple of interface engines, and they are different sizes and really meet the needs of different types of users so that we can work with you and to really understand that and make a good recommendation. Empower individuals. I love this too. Help people to just give them the tools, remove the roadblocks, let them get done what they need to in order to accomplish this. The government is not going to tell us every little step. They're going to let you have some say in what works for your facility, region, network, etc. Leverage the market. Simplify. Love that. Let's remove a lot of the extra stuff. Maintain modularity. Consider the current environment and support multiple levels of advancement. Focus on value. Protect privacy and security in all aspects of interoperability, of course. Scalability and universal access. So as we look at these, and you can certainly dive into them when I'm sure you'll want to read this roadmap now. But what I really liked about it as well is it maintains the spirit of real competition, encouraging people to be creative, to come out with the next best thing, not telling people just use this. Everybody just use this, which I know some days it would seem so much easier if they would just say, just use this. Because then you wouldn't have to do all these searches, and but really we want people to be creative. We want them to continue to come up with those great ideas. We want to have some ability to negotiate and find that next best thing for our users. So we have some categories of standards. We have the semantics, the vocabulary and code sets. So they use RxNorm as an example here. The information is universally understood. Format, content, and structure, so the syntax of it. Is it in the appropriate format? consider a CCDA, which I know we all are, we struggle with those because even though it's standard, sometimes people put their own twist on these things. So we want to make sure that it is the appropriate format. Transport, the information moves from point A to point B. Security, the information is securely accessed and moved. And the services provides additional functionality so that information exchange can occur. We don't want to hinder that or stop that in any way, of course. Okay, so now we're going to talk about your preparation and how we can look at your current setting to decide if you are prepared for semantic interoperability. So we have a current inventory of facilities in here, and sometimes this seems obvious, but it really isn't. So if we look at what's in place now, sometimes there's little clinics, there's these little offshoots. You've got your anticoagulation clinic that you didn't really consider its own thing, but boy, they have this little system that they use to document or to send results. Really consider all of those little pieces: hospitals, clinics, rehab facilities, laboratories, extended care, all of the pieces and parts that you want to connect. So what are we talking about? And then getting into the technology. What do you have in place? And this is often surprising as well. As you go out to, the diabetes counselor, as you go, like I said, to anticoag or to cardiac rehab, they might be using these little offshoots of technology that really weren't part of the bigger picture all along, but they rely on them heavily. So any little applications, best of breed, standalone, anything like that that they're using, interfaces, interface engines, mobile apps, you can fill in the blanks. It certainly doesn't have to stop here. This is just to get those juices flowing, and really consider this as you're working with your team members. And then the community connections. This is where it starts to get more and more complex as we move that circle out, the ripple effect, the physician groups, any ACOs that you are managing or serving. Network members, maybe you're part of a network, maybe what you're trying to really build here is an HIE, and you want to include many community partners who are not part of your current little bubble. You're really trying to extend this out. Population health, direct secure messaging, CCD, CCDA, anything like that, any of those ways that you're connecting to those systems that are not part of your bubble. And then, even more important, what is not automated? And we see this a lot. I just mentioned the OR. We have sites that are faxing results. They have one group that they still fax to because the EMR is not able to be, they don't have any interfaces at this time. Where are you using paper? What about reference lab results? What are you scanning? In some cases, we had a site with an ED best-of-breed system that was not automated. They print, send it with the patient to the inpatient unit, then that gets scanned and pulled in. So no trending or anything like that can be done. Of course, it's just a it's a document when they're on the unit. Are you manually importing or exporting anything? Sometimes you don't realize people are doing this. They're just trained to do it, but you have to think about, as these employees, as you lose some of that history, and it's just the paradigm, it's what they've always done, and then you lose that history and people don't, that isn't always passed on. So having that automated can really help to improve things. So I'd like to know from the group, if you don't mind, what do you feel is the greatest barrier to achieving your interoperability goals? These are the things I usually see, so you can choose one as it fits: knowledge, budget, human resources, or are you missing a champion, that administrative person, that leadership person who is behind this and helping you move that along? So I'll give you a moment to do that. And again, as during the last poll question, I'll give you the opportunity to see if there is any questions. So if you have a question, please let me know. Just go ahead and enter that in the chat box, and I'll be happy to answer that. We need the Jeopardy music going at this point while you're answering that question, but it's an easy question. So I think the time you've had is probably perfect. Let's go ahead and close that poll. And let me see what we've got here. Okay, so most people cited, so 2/3 of you said that human resources is the issue. Nobody said budget, which I think is a really true look at this. A lot of times people will say budget, and as we get down to it, and some people could consider human resources budget, but at the same time, it does come down to those resources, the experienced resources, people who can meet those needs, not just a body. And then 1/3 of you said knowledge, and I think that can go along with the human resources, so probably a little overlap there, right? And no one said they were missing a champion. I think most of us, your leadership, maybe even if they aren't looking forward to it, they know it needs to happen, so they'll get behind that with you. And so that's great. Thank you for answering that. And Sandy, I'd like to just know if there's any questions at this point.
Sure thing, Michelle. We've got a question here. We are hoping to be able to keep our existing interface engine. How can I tell if it's good enough for our future needs?
Okay, great. Well, that's actually what we're going to be getting into. And as we look at that, we can see, we take a look at all the pieces that I just went through, all of the inventory, taking stock of what you've got in place, and then where do you want to go? So really looking at your goals. So I was working with one group, and they actually were possibly going to be purchasing a smaller hospital in the community that they had been talking with for a while. They had done, the affiliation, put that in quotes, and were working toward the actual merge of the facilities, but it hadn't happened yet. But as we were thinking and recommending what they should do, we had to take that into account. So I think the best thing to do in that case is really stepping back and taking stock. What do we have now, going through the pieces that I just reviewed, but also looking ahead. And then you need to consider number of messages, what are the goals, what types of interfaces. So really looking at that, and I know I'm talking fast, but what I'll do is I think we head into that in actually the next couple of slides. So any other questions, Sandy?
Thanks, Michelle. Nope, that's it.
Okay, thanks. Okay, great. So now what we're going to do is what I love to do is I love working with our clients, and then I put into a visual what they've told me. So I don't have actual customer information in here, but this is an example. For instance, we had a site that was retiring one EMR, and they were moving to a new one. They were archiving data in a large database, and they were actually they were retiring the archive as well. So we had to come up with a plan for that. And then we had to plan for all those new interfaces. They had a lot of vendors. Some were unidirectional, some were bidirectional, and we had to consider the engine. So we looked at all of those pieces and parts, really tried to get some data. You can't always get perfect data around message volume and message size and things like that, but you can make your best guess based on your experience and the experience of the vendor who'll be feeding and receiving. So we look at all of that, and then based on that, we can make a determination. We talked to you about your future plans. Where are you going? What needs to happen? What do you have currently that might be manual, that needs to be automated, things like that. A drawing really helps. You can get buy-in from your team members, buy-in from your leadership to, once they see it on paper, it all becomes clear. So trying to just even put in bullets or just text, I've found people kind of check out because it's just a lot of words. If you can get things into a picture, it really helps. You can add some color, really looking at, the unidirectional versus the bidirectional, seeing these, a financial system, transcription system, lab, radiology, PACS. What have you got going? This isn't there yet, but they're planning to connect to their ambulatory EMR, okay? They have an HIE with which they participate, and some other hospitals feed that as well. There's an EMPI. So you can see in this visual really pulling together, again, the pieces and parts to see all of, not just the little bubble of the hospital you might be working with or the network, But outside of that, is it part of an HIE, and how do they participate? Do they just send? Do they receive? Do they get reports? Things like that, really considering all those pieces and parts. And then just one more, this is a little bit different, but taking a community of 3 hospitals where they each have, a couple of them had their own engines, feeding a larger engine, bringing in the ambulatory EMRs, pulling those into that engine. Maybe they are part of an HIE, and maybe they have a clinical portal for their network of hospitals and ambulatory, a patient portal. Maybe they want to get analytics if that's their goal. Okay, this is very similar to one that I'm working on currently, and I just modified it a little bit to just to make it look a little bit different here. But we've got all these pieces and parts that we're working with and trying to make a practical, informed decision. By doing it this way, you can really get everyone to visualize and understand what needs to happen next. In the more complex drawings that I provide, I also get into each hospital and talk about each single interface. You know, the ADT, the ORU, the ORM, we're getting lab results, we're getting transcribed reports, anything like that. We've got all the ins and outs. So these are just, you know, really an idea of how you can put that together. So as we continue preparing for semantic interoperability, now we can consider what can we keep. So we look at that first guiding principle, which I love because I think it shows fiscal responsibility, that people, they should build upon their existing health IT infrastructure. What do you have that you can still use? I guess it's you know, reduce, reuse, recycle. That's what we're going for here. And it doesn't always work. You can't always do it. But in general, if you've got something great, maybe you can just do a product or application upgrade. We have a site that is they're using Mirth. Mirth Connect has an open source version of their engine, and they need to upgrade. So we're assisting them with that upgrade to the commercial version because the open source version just is not going to continue to meet their needs. But by staying with Mirth and moving to the commercial version, all of their interfaces can just transition. It's not even really a transition. It's just an upgrade. And so they will save a lot of money in that way because they're keeping the same basic architecture and setup. So that was kind of neat to be able to help that happen. So a re-implementation of something existing. So you know, we see a lot of times that people have a system when they first put it in, they really didn't, you know, if I knew back then all the things I know today is kind of the mantra in that case of, okay, things have changed, healthcare has evolved, the system is still good, but maybe we just need to step back and have a do-over, a mulligan, if you will, so that you can re-implement. So just step back and look at how you can make that system work better. So refining, meaning you've got something good in place. Again, more of the same, just really improving on what you've already got, cutting out some of the extra keystrokes, things like that. Maybe you have a system that you can assign attributes or queries or make the cursor move where people need it to be based on responses to questions, and you've just never done that. And that can be a great morale booster, and it can help people move more efficiently, and they'll like the system better. Re-educating people. A lot of times you have people who came in, they got a quick training because they were just too busy. Well, now they're not good users. Can you re-educate them? Are they willing now to step back and become better users, really understand how to use the system? And then looking at, do you have any quick wins? So a workflow review where you can audit, adjust, and implement. So audit how they're using it, adjust where needed, and implement the changes, the adjustments that you just figured out would add value. Maybe putting a label printer in a new place. I mean, sometimes it's just something as simple as that. Every time they do it, they get up, they walk across the room, and they go and get a label, and they're always, in most cases, they are in this geographic spot in the unit. It would make sense to put it there. That's not necessarily a big interoperability thing, but by mapping out your interoperability, you can find things like that that make a difference. A barcode scanner. Are they typing in account numbers? Are there errors based on the fact that there is not a scanner? Maybe you need bedside phlebotomy or something like that, or your medication management is not barcoded completely. Dictionary and table management. Sometimes people just need the tables in the system to be more complete, more clear. We had a situation where we were helping folks who had radiology exams that were not clear. People kept ordering the wrong test, and sometimes it didn't get captured by the rad tech and the wrong test was done. They stepped back and looked at the verbiage of the choices for radiology and took the time to make them more clear, and they saw a really great improvement. An interface, those things that you're doing manually, you're exporting, you're sending to a file someone's typing in, anything like that. If you can do an interface, you'd be surprised because these things can be relatively low cost. They boost morale significantly. And some of these little things, if you step back, can really help to improve the general consensus around that things are okay. Efficiencies are put into place, and it just helps to get that buy-in and credibility from your users, which can help with next steps as you move forward. So if you found in this that you have tons of things that need to be changed, your list seems huge, stepping back and prioritizing these, really thinking patient safety first, of course. You know, you have a lot of patients who perhaps are mismatched. You have registrars who perhaps are creating new medical record numbers at registration because they don't realize that there's a match. You've got duplicate records out there. This is a patient safety issue. So that's something you might want to tackle first. Scanning, barcode scanning, again, a patient safety issue. Depending on your situation, those may be your priority items. What's going to affect patient outcomes? Maybe not patient safety as much as length of stay and the patient's experience, so that you do get folks who want to return to your facility and use your services. Turnaround time, decision support, scheduling, things like that can improve patient outcomes. Certification, what affects your ability to be certified to a test? It might be CQMs, your patient portal. If you don't have one and it's required for your meaningful use certification, then maybe that needs to move up the list. If you have one and it isn't getting great reviews, but you do have one, maybe it's not as urgent. Transitions of care, things like that. And then efficiencies that not necessarily are always clinical, but have you integrated your payroll system, materials, archiving, some of the administrative things that can help bring all of that together as well, so that you can decrease costs and then have that money to put toward other things. So really trying to understand, can your existing infrastructure be leveraged? So when you're thinking about what to replace, so sometimes we can't leverage what we have. We can't use what we have. It might be uncertified. The vendor is sunsetting that version or that technology, or it just simply is not going to meet your needs long term. So much has changed since you purchased that, it just simply doesn't make sense. Then it's time to consider a vendor search and just figure out your budget. What do you need? Where do you want to go? Those are things we're all used to doing, but before we get there, it's always good to see if we can use our current architecture. So you need to outline the work to be done and set up an action plan for moving forward. So what do you have for resources? That's always a big one, and you just had answered that, saying human resources are a big issue. of the resources you have, the expertise in-house, what can you manage? Adding FTEs, maybe you need to hire people. You know for the long haul that's what makes sense. Outsourcing is just not what you need right now. You'd rather have someone in-house, and a lot of people feel passionately about that. Sometimes outsourcing is the best bet. You bring in a consultant who can take care of it, they have expertise, and then they would move on when that project is done. So a lot of times we'll see a hybrid where you bring in a consultant with that expertise who can train and mentor somebody who is an FTE in your facility or network. So you've got project management, vendor searches, engines and interfaces, implementation consultants, testing, and analyst work. Those are all things that you might have in-house or you might want to outsource to a consulting group. And you should choose a trusted partner. I know we've worked with many of you. I know that there are other great options out there as well. And you want to make sure that you have a good relationship, that you are feeling comfortable with who you bring in. And we've worked with many of you, and ways that we've been helping people is to provide a free engine assessment. So I showed you some of the visuals that I love creating. I love working with folks to find out their architecture, and I've done a couple of these free engine assessments, and in some cases I have recommendations, and in other times I have simply provided the drawing and said I really don't think there's anything that we can do at this time. So it's not about really trying to create revenue here. We would love to work with you, but really we want to provide you with a visual that you can take. We'd love the opportunity to work with you and just to hear about what you're doing. Maybe it can help some of your peers, and if there's an opportunity for improvement, we can recommend that as well. We also have a free EMPI assessment. And so if you are unsure of your duplicate rate, how well are you doing with matching patients? You've just added on a couple of ambulatory systems and another hospital, and now you're all sharing information. What happens sometimes is that's the perfect storm, where some people might have Michelle Schneider with one L, or they spelled Schneider as Snyder, and now it's become a mess, and I actually have 3 medical records. And you need to resolve that because it's becoming a problem. The decision support that is supposed to be there is now fragmented. So having an assessment can just give you an idea. What we do is we would work with you to get a sample file and just give you an idea of how clean your data is. And maybe it's awesome, and maybe you need assistance, but sometimes just finding out where you're at is a big help. And I know that Laura put in the chat a link if any of you are interested in one of those assessments. So please let us know. Again, it is free, and we're happy to work with you. Interface engine development. We, as you know, as many of you may know, we have our Jaguar engine. It's a part of the IATRIX Systems suite of products. We also are resellers of Mirth and the InterSystems Ensemble engine. And we have certified programmers for Mirth, and Ensemble does not offer certification, but we have 6 developers who have been through the training program with Ensemble. We also work with Cloverleaf and OpenLink and CorePoint, and there are some others. Those are the ones on the top of my head here. I should have written it down in the slide. But if you need engine work, interface development, transformations done from the simple to the complex, reach out to us and we'll be happy to, we can give you a quote and see what you need and perhaps provide assistance. We also have project managers and gap analysis coordinators, so they can come in and see where you're at with your meaningful use certification. Are you ready to attest? What do you need to do to get there? And just provide you with that feedback. And then, of course, some of our solutions that will help you reach those goals are Security Audit Manager, Meaningful Use Dashboard, Bedside Barcode Specimen Collection, and interface engine and physician office integration. So if you're trying to integrate with the ambulatory EMR, our physician office integration can bring all of that together. So that is my last slide, and I just want to give you the opportunity to throw any questions in chat before we close. And even if there's something you'd like me to follow up on, if I don't have the answer, I'll be happy to assist with that. And otherwise, I'll just remind you of my contact information. You can see here my phone number and my email address. You can connect with me on LinkedIn. That would be terrific. And I also had just posted to our blog for interoperability this week, and so you can check that out. We've got a lot of content in there. We have some really knowledgeable folks who are adding to that blog and posting, and it's been a great resource for me, I know. So I would love to hear from you. So Sandy, did we get any questions, or are folks, their heads are filled with information and no new questions?
No new questions at this time, Michelle.
Okay, great. Well, thank you, everybody. I really appreciate your time. I hope that you got some good tips today and that you can take this information to put it to good use in your facilities.